Good morning. We are providing you today some supplemental information following our excellent and exceptional retrograde CTA case from last week. These have been prompted by additional questions, additional queries, and I think it's a very relevant topic. So I'll pass over to Dr. Kinney, who will provide you more information about this case.
Okay, good morning to all our CCC live viewers. And this case, which was done but 2 days ago on Tuesday, 31st of January, generated so many active questions, relevant questions, educational point of view. And so we are giving a kind of analysis, you can call it a post hoc analysis of the case, making the teaching points and which was done, why it was done. And of course, Dr. Keeney will say that. And just to say, for CCC Live, this will be the second analysis of a case done, a case in 2013, when we had a complication of patient with cardiac arrest, and patient then 3 months later, we did the analysis of that case. And similar to purpose here is to increase the educational level of our audience. With that note, I'll just take you directly to Dr. Keeney, who is prepared, justifying what was done. And then we'll go through many of the questions which were not answered during the session. So, Anu, all yours.
Yeah, good morning, everybody. I think just a couple of the slides that were shown here. Yeah. So can you see?
Yes.
Okay. So this was the case number 187. We have already presented the case was Ostial LED CTO, and we will tell you why primarily we were tried the retrograde approach. So if you see here, always when we are doing CTO, we would do a dual injection. So this was a caudal where we want to see, can we see the proximal cap? So that's one. And this is where we are trying to see the distal vessel. So distal vessel is large, disease-free, trying to identify the septal, and that ideally would be the RAO view. But see there, we have marked the septal that we thought will be connected from the PDA to the LED. And the most important is the ambiguous proximal cap of the LED. Though there was some discussion may be close to that ramus, we probably have some proximal, cap of the LED that could have been seen. So the plan was to go retrograde right from the beginning. So this is, where long time we had this publication that came back way back in 2021, that if we are doing, that is an ambiguous proximal cap and there is good interventional collateral, which is true in this case, try to go retrograde directly from the beginning. And that is what the plan is. Now, the question was that we did highlight that we have this what is called as the guide wire app, where it is only dedicated to which guide wire that we should pick. And especially in CTO, which guide wire we can take that. So going through retrograde CTO steps. So of course, what we will do is we will go through the septal collateral wiring. And the question always came that do we do the septal surfing or do we do selective injection? And I think we answered that question. Better to do septal surfing, because selective injection very rarely you can give rise to some hematoma, or very rarely difficult to understand. So septal surfing is probably the best. How do we reach the PDA? You will take your microcatheter and then you will go to the septal artery all the way with your workhorse wire, because you do not want to lose the tip of any kind of your CTO wire. Once your microcatheter is there at the level of the septal, then you will take or exchange the workhorse wire to a dedicated retrograde wire. Again, lot of discussion happened which wire to choose. So we gave a list of all the wires that could be used here. So Scion, Black, Suo, Fielder FC, then Fielder XTR. Now the best part is all these wires which we first mentioned, their tip is not tapered. Only XTR, the tip is tapered. All are hydrophilic. Many of them have polymer coated. So hydrophilic is very important. So the traversing the septal is atraumatic. So could XTR be used? Yes, could be used. But it's all what kind of wire that you have been using, and you just get used to those kind of wire. So very simple. We say that we have shown that through our ceiling camera with the nice for backward forward movements with your fingers, which is usually thumb, and you will use your index and the middle finger, so that fine movements you should be able to navigate this wire through the septal and slowly advance the microcatheter. I would say gentle advancement. So if you see here what happened, so we went to the PDA, we had the regular fielder and turnpike. So what was happening, it was going to a very small first septal. So now what we need to do is pull back the microcatheter and try to make a turn. So that kind of a turn was not possible. We tried fielder FC, not possible. So what we do, we used a run through wire, okay, because you see that tip is hydrophilic coated, but your one-to-one torque is better with the run through wire. We navigated into the PDA, if you can see here, because this is not, can you see my, what I'm pointing at?
Very nicely,
Yep.
very nicely, Anu.
Yeah, so if you see here, we did not want to go at this tip. Instead, you come back into the PDA and then get into this septal like this. That was the goal. So which wire? So that you will pull back and try to use the same fielder FC. Fielder FC was not making the turn. Many times the polymer jacketed wire, the tip, one-to-one torque may not be that possible. Like we say, the tip is not listening to your fingers. The tip has to listen to your fingers. It was not doing that. We changed to run-through wire, then able to navigate up this way. The only thing was when we did the septal surfing, for that little part, the transmission was not happening. So again, I'm going through the same wire, fielder FC, hydrophilic coating with polymer jacket. Look at the tip load, 1 gram. You need small tip loads. Okay, fielder FC tip load is smaller, 0.8. Okay, but same thing, hydrophilic coating with polymer jacket. So why we need smaller tip load? So the tip is more floppy, able to get through the septals. And then run through is our regular workhorse wire. You see that hydrophilic with hydrophobic silicone coating. That is a tip. And why you need hydrophobic? Many times your torque at the tip is better when you have a little bit of a hydrophobic area at the tip. So now this is, rundown of why these wires were used. Then going back to just to say why turnpike, you can use any kind of a microcatheter. So if you ask me, oh, I have fielder, I have pilot 150, could I have tried pilot 150? Yes, could be used. And this is what we normally use for wire escalation, and these things we have discussed in our other anti-grade CTO wires. This one I went through again, but if you go one by one, if you see, very rarely some of them are tapered. Most of the tapered wires I have mentioned here, one is Gaia, and then you have Confianza, the Progress, Hornet. All these are the wires that are mostly used for anti-grade, but you should know, very important, the tip load as well as the tip tapering. So the way we are mentioning here is the increasing tip load of these wires.
And if I can remember, I'll ask some questions which have been in between. So people did ask XTR, yes, versus why not XTA, fielder XTA. That was the question. Although you are going retrograde, but the one question was why not XTA?
So XTR, like we said, see that the polymer coating is there and tip load is smaller, was specially made for retrograde, and that is why they named it like that. One you go anti-grade A, and other one is R, retrograde, easier to remember.
Good.
So that was the reason we could we have tried XTR? Yes, we could have, but we liked Scion better, so that is why that was for. So it was used, I think the navigation, like I say, has to be atraumatic. Means the wire should find its way through the septal, and we should not be like we are doing anti-grade wire escalation where you're trying to, go drill through. You should not do that. Just the back and forth movement, the tip of the wire should find the septal itself. So we reach there, and once you are at the I would say you still call it a distal cap or proximal cap, but this will be the distal part of the LED. If you see there at this level also, when you reach, you use the same soft part because we always know the that part which is the distal cap is always softer. Usually these wires can go through. Now crossing the distal tip, you first use your same soft tip wire. It did not happen. And then you gradually go to the higher tip wire. So again, same, you start with whatever you're comfortable with. If you want to use Pilot, Gaia family, good. And of course, I like the Miracle. We started with the Miracle, and Miracle, after that, we used the Confianza Pro. So a question came, SS there was, could we have used this cart and reverse cart? So if you see there, reverse cart is you go proximally, subintimal, dilate it, and then the distal wire will get you into the lumen. And I think we have repeatedly said that we would like to do what is called as a CTO with a finesse, where you enter your proximal cap and exit your distal cap. So this is where we get the distal cap penetration. We use Miracle 3, then we use Gaia, then we use Confianza. So I hope I'm making it clear why we used each wire. So if you see, the Miracle 3 is a very old Asahi wire. You know, the tip has hydrophobic coating, and because of that, your tip torque is better to managed. Gaia and whereas Confianza, they have hydrophilic coating at the tip, and both are tapered. So many times it's easier to navigate, or what you're doing is you're trying to penetrate and drill through the in a subintimal track. So again, what happened is, yeah, SS, what did you want to say?
Oh, no, there was question also that why not use the knuckle wire technique? They felt that it will cause less dissection, less subintimal, and less traumatic compared to the tie which you use with the Gaia wire. Choices were, everybody agreed on that. The only question was that why not go with the knuckle wire compared to just little subintimal which you were there.
Yeah, so let me tell you. So the knuckle wire, yeah, the question also came, why not you use Gladius Mongo, do a knuckle, and then, use some wire to get back into the real true lumen. Like I mentioned, I think it will likely cause more trauma when you go knuckle. You're causing a dissection and more trauma of the vessel. So that is something we never try to do. I mean, that will be a real last resort. And here, definitely, I will not try to do, because we are close to left main and there is normal circumflex. You definitely do not want to cause any trauma in that area. So what happened is, now this is a very, very important I think question SS here, is that when we went from Confianza, we got into the lumen, but we were a little bit subintimal. And how did I know subintimal? We both picked it up subintimal because of our tactile feeling sensation that we have. And I think the questions were bombarded that IVUS should have been used. And I think Kiski can also chime in here that he has some experience from his exposure way back from his previous training, that in this day and age, most people will confirm using IVUS. Right, Kiski?
Yeah, so actually I'm from Japan. For some CTO expert from Japan use like for as a standard technique for like integrate IVUS. Like for this case, from the limas or circ, we can do IVUS to check the retrograde wire is in intra plug or extra plug. So we can like do less trauma. So if it's a extra plug, we stop that procedure and try the wire again. If it's come to the intima, we will proceed. So for their point of view, it's like less trauma to do the integrated IVUS for this point.
What do you say, SS?
Yeah. So no, I would say that again, there are some IVUS experts. We are good IVUS, but there are few who use IVUS in 90, 100% of cases. Maybe they will make a lot of decision based on it. I would say that IVUS probably was needed in this case first in the beginning. And that is where a lot of questions were also. That what if you put a wire in that ramus and see the ostium of the LED where it is, there was no stump. So coming back to it, retrograde approach was correct. There was, totally it was stumpless. So I'm sure our viewers and the questionnaires, people agreed on it. There was no stump. Only question was they're putting in wire into the ramus. Could you have seen the ostium, occluded ostium of the LED? And I was here. I think it's maybe for a very expert people. I will be very tough for us to do it at this time. But yes, in the beginning, there was definitely a validity to it to see if you can see the ostium occlusion and go antegrately. But I think it would have been tough the way later on we know where it originated.
I mean, right through, I understood that IVUS was always there in our plan, but as a backup plan, not a front strategy.
That is correct. Yes. All right, Anu, go.
No, I know, but the current generation training is such that if you don't, they want IVUS to confirm that we are in the true lumen. Yes, but I think if we have trained the fingers and your tactile sensation is best, you could get that also with your tactile feeling. So now the next was the same. So at this stage, if you see the guide, we had used a EBU 30 guide. So that's the guide, and we felt that the wire is not going into the guide because it's not coaxial. Can you see how the guide is facing the left?
Yeah.
It's on the roof. So this is the time also we changed the guide to 3.5, so it will be coaxial into the left main. Then also, there was a suggestion, and we went with the suggestion as well as we felt that is when you think you're subintimal, what do? You pull back. So that's why we pulled the microcatheter and went back with the Miracle. Okay, and this is where we are. So we have an antegrade wire. We pulled back. Then we use a Miracle 6 to get from the proximal part of the LED. And at that time, I think we were, because we pulled back and navigated to the CTO in the intimal area, in the lumen, we were able to get into the guide. And subsequently, we were able to do this is just a microcatheter which we can through. And I think externalization, we were gone by side with side. So essentially, once you are in the guide, okay, you have to trap the wire, whatever wire we had Miracle. So use your 2.5 millimeter balloon to anchor and trap that wire so that your microcatheter navigates through the septal into the proximal part of the vessel easily, which we were able to do. So the retrograde, so externalization wires, you need a long one, has to be 330. There are several now available, and this is exactly what we did. You see that? And now once we externalize, how do we then take the wire out? You have your, we had fine cross, if you can see here. The fine cross is here in the antegrade section. Right here is a tip, and then the retrograde, which is right here. Okay, so they have to be close to each other, kissing. And why we need to do that is that if you don't do and you just try to take out your wire out from the RCA, what we call is we call this a cheese grating, where it can cut the wire. If when you're just removing the wire, it can cause trauma to part of the septals in the PDA where it's originating, and it can actually cause hematoma, and rare situation you can even cause pericardial effusion. So we have to be very careful. And during this time there'll be a lot of guide movements backward forward, so you have to be very gentle when you do that. And of course, now you have your fine cross in the main vessel, and then you will advance your any workhorse wire through the fine cross into the antegrade. This is what. So now what you do, you confirm your RCA is okay, the septals are okay, there is no any issue with the septal or trauma to the vessel, then you take your feeder catheter out. Of course, then we dilated. Once we dilated, that's when we did the IVUS. These steps we went through, the very important that you need to pay attention to your guide catheters. IVUS here, yeah.
Samin, go ahead. You may have some additional questions.
No, no, but just basically was the same way. One question keep coming back that should you put a protect your circumflex or left main circumflex by integrate wire? So but that apparently, but I've been to some of those live cases. People do it, but we were confident that even we'll be a little subintimal. We are not going to compromise the left main and circumflex, so that we did not do the wire. So yes, some people do teach wiring, but if you that requires your 7 French guide, because more wire there, more thrombus formation, and I've witnessed that in many live cases. That even because you always keep ACT a little low and putting additional wire if not necessary. Yeah, if you have some trouble engaging the guide, disengaging the guide, causing little dissection, you see some diastasis, then you can protect. But otherwise, we never felt that we will be required in this particular case.
Kiski?
Yeah, yes. I agree for the Dr. Sharma.
No, but with this IVUS guided re-entry.
Sure. So this is the first paper from the 2016 for cardiovascular intervention, state of the review for the IVUS usage for the CTO PCI, and especially for the antegrade approach. So you can see that the left panel, there is an IVUS catheter in subintimal. So coronary artery is 3-layer, intima, media, and adventitious. But this red one is we cannot see the media. So media is disrupted. So it means the IVUS catheter is in the subintimal. So, but then we put that IVUS catheter in the subintimal and go live. And we tried another wire to see the second wire is gonna be the true lumen. So then this yellow line, just Dr. Kinney pointed out, there is a intra plug. So it means the true lumen. Then we can go for procedure in that true lumen IVUS. So that's how antegrade re-entry. Then second one is just Dr. Sharma mentioned for proximal cap puncture. So if there is a good side branch, like for this case, a good circ or good limus, we put the IVUS live image here. And for the second wire to try to puncture this true plug, intra plug. Then the left bottom, right bottom, there's a guide wire at the central position of the side branch. Then we can confidently say the guide wire is true lumen. So we can go forward with less trauma. That's how we use the IVUS for the CTO for antegrade approach. Yeah. And of course, it's important to, after we cross the wire, then sizing based on the vessel diameter or lesion length and plug morphology, how much calcium, lipid or thrombus or something. And after the stenting, we can do the stent optimization to get the MSR or less complication like edge dissection. And actually, this is the initial pullback after we did a pre-balloon. And we are very relieved. The start of the pullback, like cross section of the air, is guide IVUS catheter is in the true lumen because the all intact media. And we can also check the vessel size, 3.5, but concentric fibrous plaque. Of course, it's a CTO lesion. We cannot see the true healthy lumen. So we decided to do the one size down 3-year-old stent sizing. But if come back to the proximal just before the first septal, it started come inside the subintimal. So, and you see the true lumen is expelled by the subintimal. So before the septal, it come into the subintimal. Then come back to the ostial LED. It's come back to the true lumen. And you see the circ branch from 12 o'clock and limus branch from 3 o'clock. So, and IVUS catheter just come back to the true lumen. So it just starts at the ostial LED, at the trifurcation. Then come back to the left main. It's a true lumen, but there is a hematoma because we did some subintimal tracking. But yeah, but lumen is open and lumen is 4.6. So on the summary, the IVUS catheter is from true lumen, subintimal, and true lumen that we found from the initial IVUS program. Then we put the yeah.
Then we did the balloon stent, and this is the post-stent IVUS pullback. So you have distal left main. The proximal, there was some, under expansion. So we post-dilated with 4O up to 20 atmospheres, and then we had a final. This is the, right? This is the final.
Yeah, no major malposition and a good stent expansion. MSA was 6.1 and a distal edge no dissection. So stent result was excellent.
Yeah.
I can tell you very educational case in terms of how the IVUS, even if we did in the end, that we learn a lot. And Kiski has really masterfully demonstrated that how we were subintimal, true lumen, but subintimal, and then went into the true lumen, which is a phenomenal. So true lumen, subintimal, true lumen. Very limited dissection at the ostium of the LED, but then left main was in the true lumen. Fantastic.
This is just a final slide to say, yeah, you can do CTOs. The question is the same. I think when you do these complex procedures, why it's important that things have to go smoothly and at a right time in a quick fashion. So our air karma was just about 4.4. The contrast was about 220 or so. So everything met the guideline directed CTO recanalization. The patient was a little bit uncooperative, if you can see it, but operator fatigue definitely did not happen. And as at the end, we've shown that no major complication. So this is where we are, that we were able to get this procedure successfully done.
Anu, I think this is a fantastic focused summary, which also provides a supplemental tips and tricks, and you have continued to emphasize throughout a step-by-step approach. And of course, Kiski provided a next level IVUS tutorial. Sameen, Anu, Kiski, any final reviews? Otherwise, we excuse ourselves till the next session on February 18th. Sameen, go ahead, please.
One last question, and I don't know whether it was a sarcastic or complimented. So I think we should talk about. Let's say one was that how not to do a CTO PCI. I expect this question referred to that we do not do more antegrade dissection and so which is associated with higher stenosis and occlusion and lower stent patency and so on and so forth. So basically trying to show least, and I've been to so many these live cases and with the Japan, and so they keep trying for 6 to 8 hours. And remember, every case they take a last picture with the contrast through the catheter, whether it's a Corsair or a Turnpike microcatheter, and you see a lot of blush. You saw this particular case; there was no blush. All no basically perforation, no extravasation, least traumatic retrograde CTO, I would say I've seen in a long, I mean, I've never seen this kind of a phenomenal case with the least trauma to any existing vessels or any side branch. Only question, as I said, that's could we have used IVUS to help us to get into that criticism? I will take it full with the open arms and learning, because we all learn. When Anu put a wire into the circumflex, then putting the wire and so, but the point is there are various ways to do it. But I think the Anu showed her way to how to do it with the minimal trauma, little bit of dissection, which is inevitable in the CTOs. But the final result with every septal, every diagonal, no left main dissection, slight distal tip hematoma of the distal left main, which covered by the two struts of the LED stent, was a prime example of thoughtful planning and execution of the case.
Sameen, in closing, I want to thank our viewers again. They kept the session magnificently interactive, and I am confident that this supplement will be even further helpful. We'll see you during our next transmission on February the 18th.
Thank you.
Thank you.